over 80% of the patients were able to help. Food and stress are the two main triggers. Most IBS patients that experience this interaction between the brain and the gut.
Today we're talking all things IBS, Irritable Bowel Syndrome. Our guest is Dr. William Chey, board-certified gastroenterologist and professor of gastroenterology at the University of Michigan, where he is also medical director of the Michigan Bowel Control Program, a state-of-the-art multidisciplinary program for patients with IBS and other gastrointestinal conditions. Dr. Chey has published over 400 scientific articles and book chapters on gut health and IBS, and is a regular author on national gastroenterology guidelines. He has received a number of prestigious awards over his 3 decades of clinical and research experience. We talked about what causes IBS, how to identify it, how to distinguish it from other conditions that can look like IBS, that can mimic IBS, and finally, therapeutic approaches, including diet, low FODMAP diets, and others, and also medications, probiotics, acupuncture, and a lot more. As always, the goal is to bring the leading scientific voices in the world straight to your electronic device, free of cost. So I hope this helps you on your health journey.
IBS is a really common and bothersome condition. So it's not a disease, and when I say that, I use that term disease as a condition that's defined by a specific diagnostic test, for example. IBS is a symptom-based diagnosis. So patients with IBS have to have characteristic symptoms, which include abdominal pain in association with altered bowel habits. And I think one of the really confusing things about IBS for lay people in general, and actually for doctors as well, is the fact that patients can have constipation or diarrhea or a mixture of constipation and diarrhea. And as long as they have abdominal pain that's associated with their bowel habits in some way, that still falls under the rubric of IBS.
So there is this division between IBS-D, IBS-C, and that's just a clinical discrimination, right? IBS, if it's predominantly diarrhea, it's IBS-D. It's a predominantly constipation, we call it IBS-C, and then there's IBS mixed. Is that?
That's right. That's right. And it'd be wonderful if patients, quote unquote, stayed in their lane over time, but they don't, and it turns out that as many as a third will experience dramatic changes in their bowel habit symptoms over the course of a year. So patients that start off with IBS-C can migrate to IBS-D or IBS mixed over the course of time. The majority do stay stable, but that around a third will migrate to one subgroup or another.
Mm-hmm. Yeah, so a lot of heterogeneity, it sounds like.
Yes, that's the key. That's correct. It's not one disease. Yeah.
Yeah. Is bloating a common symptom as well?
Bloating is very common, and it's not part of the diagnostic criteria, but probably upwards of 85% of patients with IBS report some degree of bloating. So the vast majority of patients experience bloating. The problem is, people that are listening probably are saying to themselves, God, if 85% of patients with IBS have bloating, why isn't it part of the diagnostic criteria? Well, here's the problem, is that a very high percentage of many other conditions, things like, for example, functional dyspepsia or anorectal disorders, will also have a very high prevalence of bloating. So while it's really common, it doesn't discriminate between IBS and other conditions.
Got it. What about difficulty passing gas or burping? We had a lot of viewers ask about that as well. Can that be part of IBS?
It's not part of IBS, but they're symptoms that are very common in IBS patients. So I just want to make sure that we understand what I mean by that. So again, they're not part and parcel of the criteria to define IBS, but IBS patients often have overlapping upper and lower GI symptoms for other conditions that we would think about: functional heartburn, functional dyspepsia, fecal incontinence, that aren't part and parcel of IBS, but are common in IBS patients.
Mm-hmm. So it's like bloating. It's common for people with IBS to have them, but these bloating and difficulty passing gas can also happen in other conditions, non-IBS related.
That's right. That's exactly right.
Okay, we're going to get into like what is known about causes and a lot of differential diagnoses. But first, I just wanted to get a little bit of the basics in terms of how common IBS is. I've read that the frequency is increasing over the years. Is that true?
Yeah. So first off, the prevalence of IBS, how commonly it occurs, depends on how you define it. So there are different types of criterion that can be utilized to define IBS. The most commonly used ones are the Rome criteria. The current iteration are the Rome 4 criteria. And if you use the Rome 4 criteria, somewhere between around 5 and 10% of the general population, depending upon the country that you're talking about, will actually satisfy the diagnostic criteria for IBS. So it's a very common problem. In fact, it's been estimated to affect anywhere between 15 and 35 million people in the United States, for example. So it's a very, very common condition.
And this idea that it's increasing, is there any truth to that?
Oh, that it's an interesting question. So I'm not sure there's really compelling data that it's increasing until recently. And here's the reason why I say that. Is there's been several papers published now about an increasing prevalence of IBS since the pandemic. It turns out that acute infections, in particular GI infections like food poisoning or traveler's diarrhea, dramatically increases your likelihood of developing long-standing symptoms that would be consistent with the diagnosis of IBS. But intense infections in general have also been associated with an increased risk of developing IBS symptoms. And there have been now at least 2 papers, actually 3, counting a paper from our group, that suggest that the prevalence of GI symptoms in general and IBS symptoms more specifically have increased since the pandemic.
And that's related to COVID having some effect on the gastrointestinal system?
Well, that's actually a very interesting question too, because so it could be that increased prevalence that we're seeing is a consequence of the COVID infection. So again, like a post-infection IBS, or it could be related to other things associated with the pandemic: changes in diet, changes in physical activity, changes in psychological stress. Right. That could all influence. And the answer probably is it's all the above, right? Yep. It's probably all of these things to varying degrees in a specific individual that makes them either more or less susceptible to IBS. Here's the other interesting thing. Not a lot, but some of my patients actually told me that their IBS symptoms got better during the pandemic. Why? Because they were preparing all their own meals, because they were working from home. They weren't having to go out in traffic and get stressed out related to all the sort of headaches that we deal with in everyday life. So some people got better, some people got worse.
Mm-hmm. Yeah, it's always the problem with the ecological associations is all these multiple moving parts. It's good for hypothesis generation, but then we need other types of experimental designs to really nail the cause and effect.
No doubt.
Yeah.
No doubt.
In terms of age, what is the most normal, most common onset? Is there a specific age of people who report the symptoms?
Well, I think the first thing to say is that IBS can affect any age group. It tends to affect, at least in Western countries, younger women. So it tends to gravitate towards individuals under the age of around 45. But as I said a moment ago, by no means is it true that IBS doesn't affect older people. It's just that it's more prevalent amongst younger people and it's more prevalent amongst females.
Mm-hmm. Because I heard if the symptoms first onset after the age of 50, that we think of other things, but is that more variable? Is that not that simple?
Yeah, I think And it's not to say that the majority of people with IBS symptoms over the age of 50 don't turn out to have IBS. They do. But here's the concern is that most of the common cancers that we deal with in day-to-day life, in particular things like colon cancer, increase in prevalence as we age. So we always say that new onset of symptoms, and in this case, IBS symptoms, warrants a more detailed evaluation, particularly to exclude the presence of colorectal cancer. And, here's the good news is think about it. The new screening criteria suggest that we should be doing a colonoscopy to screen for colon cancer, at least in the United States, for everybody over the age of 45. So it really aligns very nicely with the prevalence data in terms of age thresholds that I reviewed for you just a moment ago.
Let's get a bit deeper into the cause of what's known about what causes IBS. A lot of the questions from our viewers were regarding cause, and there's an idea that it's still very much a mystery or incompletely understood.
Yeah, I think that's a better way to say it. We've learned a lot about the pathophysiology of IBS over the past 2 decades. In fact, there's been a tremendous amount of attention and a tremendous amount of discovery in regards to the pathophysiology of IBS. And again, as we started out this conversation, it's important to recognize that this isn't one disease. And so there is no quote unquote silver bullet in terms of the pathophysiology of IBS. Rather, it's about understanding the factors that can come into play to enable the expression of symptoms in an individual. Okay, and that's a complex milieu. If you believe in the biopsychosocial model, which I do, it's probably an interplay between physiologic factors like abnormalities in motility, visceral hypersensitivity, altered permeability, intestinal permeability, or leaky gut, in association with important factors that reside within the gut lumen. So things like food, things like the microbiome, things like bile acids. All of these things interact to lead to activation of the immune system that resides in the GI tract, as well as the enteric neurons that reside within the GI tract and act locally through things like motility and visceral hypersensitivity, and systemically as well as with the brain through gut-brain interactions and brain-gut interactions. Both of those things are important to varying degrees in patients with IBS. So you can see that it's a complex system with a lot of potentially moving parts. And what leads to IBS symptoms in one patient may not be the same as what leads to IBS symptoms in another patient. I think that some truths which are operative in the vast majority of IBS patients are that the most common triggers for symptoms include food, present probably more than 80% of IBS patients will say that their symptoms are either triggered or worsened by eating a meal, and stress. So food and stress are the 2 main triggers, not universal truths, but present and important in the majority of IBS patients.
Do you think that this complexity and this heterogeneity in the future, as more is known and maybe different tests are developed, do you think IBS will kind of multiply into different disorders, more specific, or do you think it's just individual susceptibility that causes this individual variability?
I think both are true. So here's the thing: is think about what's happened over the last. I've had the benefit of doing this for more than 30 years now, and in my time, we've unlocked the issue about the overlap between celiac disease and IBS. When I first started out, that was not recognized. It was actually some of our work that was some of the first work that really pointed out how commonly that occurs in patients with IBS. We've identified that patients with microscopic colitis can masquerade as IBS. And there's been a lot of discussion about bacterial overgrowth. So you think about just how IBS has evolved in terms of the way we think about it, and that a lot of these other diagnoses, not so much SIBO, but certainly microscopic colitis, celiac disease, inflammatory bowel disease, cancer, we recognize they can all have symptoms similar to IBS, but that they separate out related to diagnostic testing into specific diagnoses that are not IBS.
Mm-hmm.
I think that same thing is going to continue to be true with a variety of other conditions. I also think that there will be diagnostic tests that help us to parse patients with true IBS more on the basis of underlying pathophysiology, which hopefully the pie in the sky is to link a biomarker result to a specific treatment for a specific patient. Now we're a ways off from that. You could argue that the closest thing to that right now is doing a breath test and using antibiotics. But even that is highly controversial. If you were to have 10 experts to sit down and debate about this, 5 would be on one side and 5 would be on the other side.
Mm-hmm. Let's touch a little bit on some of those topics that you brought up. I mean, a lot of this stuff is fascinating, maybe starting with the gut-brain axis and this relationship between the brain and mood disorders and anxiety and gut disorders. This seems to be very common. A lot of people have both. Do we know if it starts in the gut, and then what's the egg and the chicken here?
Yeah, yes. So that is the big question, right? Is what's the chicken and what's the egg? Because we know, as I said a moment ago, that stress and anxiety can induce GI symptoms. On the other hand, we know that GI symptoms can induce stress and anxiety. So it's bidirectional. And it's not exclusively top down or bottom up. Oftentimes it's both. And in fact, for most IBS patients that experience this interaction between the brain and the gut, it becomes circular.
Mm-hmm.
And it really speaks to the potential importance of these brain gut therapies. And those can either take the form of behavioral therapies like gut-directed hypnosis, cognitive behavioral therapy, for example, or pharmacological therapies. So things like neuromodulators, whether you're talking about tricyclic agents, selective serotonin reuptake inhibitors, selective norepinephrine reuptake inhibitors, or, and what's really interesting, are microbiome-based strategies, because we're coming to the realization that the gut microbiome plays a role not only in gut health, but also in mental health. So there really is not only top-down brain-gut, but also bottom-up gut-brain. And we know that from studies in animals where you can take the stool from animals that are expressing depressed behavior and implant that and graft that into normal mice or rats and reproduce that abnormal behavior. We also know that now from recent studies that you can actually provide probiotic supplements and manipulate the degree of anxiety and mood abnormalities in patients with IBS. So there's quite a bit of evidence starting to point to the fact that we may be able to manipulate the gut microenvironment and enact not only effects in the GI tract, but also far beyond.
Mm-hmm. So it seems like it's the case, at least sometimes, that treating directly the gastrointestinal condition with probiotics can have a psychological effect or a mood effect. And the opposite is also true, that cognitive behavioral therapies and things of that nature, psychotherapies, can also improve top down. So it's this cycle you were talking about.
That's exactly right. And that's why I think it's really important for people to not get overly fixated on one or the other. It really is probably circular. And interrupting things at one point or another can offer benefits to some patients. But it's fascinating how we've come first full circle on, you think about it, back in the 1950s, 1960s, people thought of IBS as a psychological condition. I mean, that was the prevailing wisdom, is that IBS was the GI manifestation of psychiatric disease. Then, if you think about it, like in the 70s and 80s, we really got away from that. We really said this is not all in your head, and this is a physiologic condition. We talked about things like motility abnormalities, visceral hypersensitivity, so problems with nerve sensing or cognitive interpretation of pain signals. But now we're sort of coming full circle, and we're not saying that it's all in your head, but we're saying, you know what? What's happening in your head is important to the overall symptom experience of IBS. So it's funny how we're going back to the future a little bit.
Yeah,
but I emphasize the little bit part.
Right. And yeah, when we say something is in our head, doesn't mean it's not real, and it's part of physiology. It's all biological at the end of the day.
That's right. That's right.
With the microbiome, that's another big topic, and a big topic of questions as well from people. People are very curious about the microbiome. There's an idea, and I've subscribed to this at some point, but I now suspect it's too simplistic, that there's dysbiosis, an imbalance of the gut microbiome. In some cases, for example, people go on antibiotics, and that might mess up the gut flora or wipe out some key species, and that could be the underlying explanation for IBS in some cases. Is that too simplistic? Is it a factor in some situations but not others?
I think that the key thing you said is in some cases. And by the way, you could say that phrase in some cases for every evidence-based treatment that we have for IBS, not just microbiome, all of them, right? But I think what a lot of times people forget is, think about what is the percentage of patients that get better with rifaximin? 43%. 43% is what the phase 3 trials would say, what the last target trial would say, what our meta-analysis said when we summarized all the data on this topic. And what that means is that 60% of the patients don't get better with antibiotics.
Mm-hmm.
Okay, so that's the first thing. The second thing is, if you look at the probiotic data, patients love probiotics, right? Probiotics optimistically make 40% of patients better. Most of the studies don't even show that percentage get better. So the microbiome strategies, they do work for some patients. And the good news about the patients for which they work for us. So for example, my clinical observation has always been that not that many of the patients that you treat with rifaximin get better, but the ones that get better get dramatically better. So the magnitude of benefit is quite profound, even if the overall response rate isn't that profound. Now, you can improve that response rate by doing a breath test. So the breath test, rather than 43% with no breath test, if you have a positive breath test, it probably goes up to 60 to 70%, which is a heck of a lot better than 43%, right? But it's still not perfect. Even with a breath test, it's still not perfect. And certainly you won't find me arguing that a breath test is a perfect test. It's not at all. It's just the best test that we have right now. So microbiome-based strategies, absolutely real, absolutely proof of concept. I think the fact that a proportion of these patients get better teaches us that it's an important concept for some, but not all.
Mm-hmm. It sounds also like what I heard in some of the presentations at gastroenterology meetings, that about 50%, if I remember correctly, of patients benefit from a low FODMAP diet.
That's right.
So it sounds like a lot of this stuff is empirical. Like you try some of these things, works for some patients, doesn't work for others, and you look for strategies that work for each patient. And for the most part, there isn't a foolproof test. But as you said, the breath test could be one indication to maximize the benefit of the antibiotic in this case.
You're right. If you've listened to any of my lectures, this is what I always say, which is that most of the evidence-based therapies for IBS make 40 to 60% of the patients better, which means that a significant proportion don't get better with any of the individual strategies that we employ. And this is why it's so important for clinicians that are taking care of patients with IBS to be familiar with the options that have been evidence-based and to have them at their disposal, because it's typical. The vast majority of the time, we're utilizing more than one strategy in an individual patient. And here's the good news: this is based more on my clinical observation, again, as opposed to a study, although I will quote you a study in a second. My clinical observation for years has been that if you come to University of Michigan, who has fully trained registered dietitians, has expert GI behavioral therapists, physicians that are dedicated to caring for patients with DGBI, disorders of gut-brain interaction, I think it's actually the vast majority of patients that we're able to help. I'd say over 80% of the patients we're able to help. So it's not 40% or 50%, it's like 80%, 80+%. But it's because we're tailoring and combining strategies in each individual patient to get the optimal benefit. As proof of that, I would say that there's recently studied something called the MANTRA study from Melbourne, Australia, where they compared outcomes in patients with functional GI disorders, the majority of which had IBS, not all of them, but the majority, 60% or so, had IBS. These patients were randomized to either integrated care, so care that was delivered utilizing a gastroenterologist, a dietitian, a behavioral therapist, a social worker, other members of the team, versus traditional GI-centric IBS care. And the good news is that even with the GI-centric IBS care, around 60% of the patients got better, which is pretty good. That's not bad. 65% of patients. That's better than what I told you in the trials. Again, because you can combine things, right? The integrated care group, though, the group that got that collaborative team-based care, 84% of the patients got better, completely consistent with what I told you from our clinical experience. Mm-hmm. And so it takes a village. IBS treatment in 2023 is a team sport. It's not just dependent on a primary care physician. It's not just dependent on a gastroenterologist. It takes a village. You have to have the correct assets to be able to deploy in various combinations in each individual patient to optimize outcomes.
Mm-hmm. And the prongs of that system that you're talking about, in brief, would be a gastroenterology team, dietitians that are specialized in gastroenterological conditions, and then therapists, psychotherapists, and psychologists. Would those be the main prongs? Is there another?
Yeah, and the other thing that we're doing, we're actually starting next month, on the middle of May. We're starting an integrated acupuncture clinic. Will also be part of our multidisciplinary team. I think we're probably the first major academic medical center in the United States to do that, but we're really excited about the possibilities. And the reason we're doing that is because we feel strongly that acupuncture is now an evidence-based therapy for a number of GI conditions, including chronic constipation, IBS to a lesser degree, but there is some very good evidence for certainly some symptoms in IBS, certainly nausea and vomiting. It's an evidence-based treatment option. So we feel strongly that to further increase the likelihood of benefit, we're going to bring this additional tool to bear in the treatment of our patients with DGBI and predominantly IBS.
Mm-hmm. Yeah, I saw some of the studies with acupuncture. And the control group, I think, was a sham acupuncture procedure.
It's interesting that you bring this up, because for IBS, it's quite controversial as to whether or not acupuncture makes the overall symptoms of IBS better to a greater degree than sham acupuncture. And, you could argue that acupuncture is not effective. You could also argue that sham acupuncture is almost equally effective, depending on how you look at it. And the studies are mixed. Some studies do show benefit. Certainly the studies comparing to usual care at a baseline all show benefit for acupuncture for overall IBS symptoms. The ones where there's controversy are the sham controlled studies that you're talking about. Constipation, no question. Electroacupuncture at ST36. There are now multiple studies showing benefit for chronic constipation. Nausea, vomiting, as I said, actually the person that did some of the original electroacupuncture studies for nausea and vomiting was my father back in the 1980s at the University of Rochester. So that is also firmly established as an evidence-based treatment for that. And then chronic pain, right? We use acupuncture all the time for a whole wide range of different chronic pain disorders. And GI is, you'd be hard pressed to imagine that the GI sources for pain should behave any differently.
Yeah, and this gets into the whole gut-brain axis conversation, because if there is a component of placebo effect, it could be through some top-down mechanism of perceiving this care to be helpful and then feeling better. But I mean, depending on the risk of an intervention, if it's low risk, then there could be value, even if it's through a placebo, by hook or by crook. If it's providing relief and there's no clear risk there, it could still be valuable.
I couldn't agree with you more. And this was another value prop to adding acupuncture, right? Is there's very little downside. The one issue for acupuncture, which is important in the United States, is it's usually not covered by insurance. So there's an incremental cost that patients oftentimes have to bear. Not always, but oftentimes they have to bear that. So that's something that we're going to have to work through. But nonetheless, we feel strongly that the standard for treating patients, particularly patients with severe IBS in 2023, is integrated care. It's not GI. It's not a GI or a primary care doctor alone. It's integrated care.
Still on the topic of the tests to raise the probability that a specific intervention is effective. We talked about the breath tests. There are some other tests that I've read about: a calprotectin stool test, antibody tests against vinculin, and some other molecules like that. What is known about this? What is the evidence behind these for?
Well, the guidelines. The one that I'm most familiar with is from the ACG, because I'm a co-author on that one. And what we said in the ACG, the American College of Gastroenterology guideline on the management of patients with IBS, was that it was worthwhile to pursue serology testing for celiac disease, because again, celiac disease can masquerade as IBS. That it was also worthwhile to do either a fecal calprotectin, preferably, or if you can't get a fecal calprotectin, a CRP level, a C-reactive protein level, to exclude inflammatory bowel disease. Now, a number of years ago, my group did a meta-analysis looking at the value of inflammatory markers like fecal calprotectin, fecal lactoferrin, CRP, to exclude inflammatory bowel disease in patients that present with IBS symptoms. And what we found was that at certain thresholds, a fecal calprotectin of less than 50, a CRP level of less than 0.5, that if you had a negative fecal calprotectin or CRP, that the likelihood of inflammatory bowel disease was much less than 1%. So you essentially excluded inflammatory bowel disease with those tests. I think that depending upon where you reside, if you're in an area where Giardia is present, that particularly during the summer months, for patients with diarrhea, you should also do a test to exclude Giardia. As a routine, you don't need to do it in everybody. But again, during the summer months in Michigan, for example, Giardia is endemic. And, we should be screening. In fact, literally last week, I diagnosed a patient with diarrhea as having Giardia. Testing for Giardia can and should be done. There's more recent testing or more recent debate and discussion about testing for bile acid malabsorption. And right now in the United States anyway, that's largely done through stool collection and quantitation of bile acid levels. But in Europe, where you're at, there's something called the CCAT test, which is available in some countries that can also help you to identify patients that have evidence of bile acid malabsorption. And of course, patients that have evidence of abnormal bile acid absorption, either on the basis of quantitative testing or a CCAT test, are more likely to improve with a bile acid sequestrant like cholestyramine or clesphlam.
Mm-hmm. And these antibody tests, anti-vinculin antibodies, anti-CDTB antibodies, is there evidence behind these?
Yeah, there is evidence, but I would argue that it remains somewhat preliminary. I would love to see additional data from a wider audience of investigators, using appropriate control groups to get an idea about how accurate the tests are. Right now, almost all the validation studies have been done in populations with defined disease. So, in other words, you could say these tests can distinguish between patients that have IBS and have inflammatory bowel disease, for example. That's not how we use tests in clinical practice. The way we use tests in clinical practice is we take all comers with symptoms.
Yeah.
We apply the test and then determine how accurate the test is at identifying a specific diagnosis. That has not been done with those tests yet.
Mm-hmm. What about the zonulin test?
Same thing. So preliminary tests showing that there are abnormalities in patients with IBS. So confirming this notion that a subset of IBS patients have abnormalities in intestinal permeability. I think we all, at least I certainly accept that at this point. But whether or not that finding is ubiquitous enough to serve as a diagnostic marker for IBS, and whether or not it's specific enough to distinguish from other diseases, like, for example, patients with inflammatory bowel disease also have abnormal permeability. I think remains to be seen. So I don't think those tests are ready for prime time as true tests to identify patients with IBS, but it's fair to say that patients with IBS are more likely to have an abnormal permeability test.
Got it. So a bit more on the different conditions that can mimic as IBS or can look like IBS. So we touched on IBD. Is a colonoscopy helpful there? It can diagnose IBD, right? But in the case of IBS, it's unremarkable.
I think that the most important message for everybody is, and this reflects a U.S. bias, but I feel like the most important thing to remember about colonoscopy is to make sure that your patients have undergone age-appropriate colorectal cancer screening, whatever the recommendation is in your specific country. If you do a colonoscopy in a patient with IBS and diarrhea, it's very important to get random biopsies to exclude microscopic colitis, because in a recent systematic review meta-analysis, it looked at the diagnostic yield of colonoscopy in patients with IBS symptoms. Somewhere between 2 and 5% had or ended up with a diagnosis of microscopic colitis. So that may not sound like much, but realize that in the world of IBS, for the diseases that we look for, like when we think about colon cancer, inflammatory bowel disease, usually those are less than 1%. So a disease that occurs at 2 to 5% is definitely worth looking for.
So if somebody comes in with pain and altered bowel habits, and clinically it could be either IBD or IBS, what are the tests that you conduct, and how does someone know if it's one or the other?
So bottom line is that when you initially evaluate a patient with IBS symptoms, you're going to phenotype them on the basis of their bowel habits. So presumably they all have abdominal pain. You're going to determine, are they more so constipation, diarrhea, or a mixture of both? If they fall into the IBS with diarrhea category, you're going to definitely do inflammatory markers. So again, preferably a fecal calprotectin. If a fecal calprotectin is available, a CRP to exclude inflammatory bowel disease. You're going to do celiac serologies to exclude celiac disease. You're going to make sure the patient's undergone age-appropriate colorectal cancer screening, and if they get a colonoscopy, get biopsies for microscopic colitis. And then the things that are more debatable would include testing for bile acid malabsorption and also breath testing for bacterial overgrowth. For patients with more constipation symptoms, to be frank, it's really almost all about making sure that individuals have undergone age-appropriate colorectal cancer screening. We do really little other diagnostic testing. I would say that it's completely reasonable, and you probably should always get a CBC as well, just to make sure there's no evidence of unexplained anemia.
With regards to celiac, there are other related conditions, right? So a person can test negative for celiac specifically, but it can have a wheat sensitivity or a wheat allergy of other kinds.
Yeah, and I like the way you said it, which is not gluten sensitivity. It's wheat sensitivity, or wheat intolerance is probably even more accurate. The reason why I say that is because people, particularly lay people, really believe that gluten is the main culprit that leads to IBS symptoms when you eat wheat and other gluten-containing foods. The reality is that while gluten can cause reproduced symptoms or trigger symptoms in some patients with IBS symptoms, the more likely culprit for reproducing symptoms in IBS patients are fructans, which are basically sugars, short-chain carbohydrates that are not absorbed by the human small intestine and are available for fermentation by the bacteria in the colon. So they're actually part of the FODMAP group. And so since we have no way to discern whether an individual is developing symptoms as a consequence of gluten or fructans, or the last thing I'll introduce is the nocebo response. That is, if you really believe that wheat's going to cause you problems, you're more likely to get problems after you eat wheat that have nothing to do with either gluten or fructans. So the nocebo response, as opposed to the placebo response, is also very important in regard to different intolerances to food. But bottom line is that's why we've migrated towards wheat intolerance or wheat sensitivity as opposed to gluten sensitivity. And we have no specific test right now to identify patients that have wheat intolerance. And as I just explained to you, it's also a heterogeneous group. There is not one cause or symptoms in patients that get problems when they eat wheat. I've just reviewed for you three, right? Gluten, fructans, as well as nocebo response. By the way, we a number of years ago created a great educational video. Some people listening may be familiar with TED Talks. There's also something called TED Ed, which are animations that are developed on various topics, including health topics. And we developed one entitled "What is Gluten?" And it actually walks you through and explains why people get symptoms, the different reasons why people get symptoms when they eat wheat.
Yeah, I watched it. We'll link it in the description for people to check it out.
Thanks. Yeah.
So you touched on SIBO and being a bit there being a little bit of controversy there. Can you elaborate on that? What is the overlap between SIBO and IBS?
Yeah, I think there's less and less controversy about the potential importance of dysbiosis in some individuals with IBS, but there's a lot of controversy about what constitutes dysbiosis in IBS. Is it more problems in the small bowel? Is it more problems in the colon? What kinds of changes in the microbiome are those that lead to dysbiosis and clinical problems? These are all open questions right now. And finally, even if you're a believer in small intestinal bacterial overgrowth as a cause for IBS symptoms, what's the best way to diagnose that? Is it better just to give antibiotics empirically, or is it better to do some kind of a test? And if you're going to think about a test, what kind of test? Would you do an upper endoscopy and aspiration of fluid from the small bowel for quantitative culture? Or would you do a breath test where you give a carbohydrate substrate and look for an increase in breath hydrogen or methane excretion as a reflection of fermentation of the carbohydrate in the small intestine? Each one of these things has their own problems and strengths and weaknesses, and I'm sure we don't have time to go through all that. Suffice it to say that, as I said earlier, if you were to have 10 experts on your podcast right now talking about this, you'd get 10 different answers. And I can tell you that literally we at meetings, at advisory boards, at symposia, you'll get a group of us together, and we will literally just sit around and debate about this for extended periods of time. There is no consensus. If you want my own personal bias is you should do a breath test. And I'll tell you why. Is because I would much rather think about giving an antibiotic, especially a really expensive antibiotic like rifaximin. Remember, the average wholesale price of rifaximin is $1,600 for a 14-day course in the United States. And remember what I said earlier, which is that the response rate to an empiric course of rifaximin is 43%. Okay? Not to mention the fact that you're giving a broad spectrum antibiotic to large numbers of individuals. Now, the good news is there's very little in the way of resistance that's been reported to rifaximin. But here's the problem. At least in the United States, for the patients that you write a prescription for rifaximin for, I would argue that only a very small percentage of them end up getting rifaximin because their insurance doesn't cover it. So instead, they end up getting Cipro or Augmentin or Bactrim, any of a whole bunch of systemic antibiotics, which are, by the way, not evidence-based in IBS and associated with development of systemic resistance. Mm-hmm. So to me, anything we can do to increase the likelihood of response, we should be doing. But I can tell you that many, many, many experts do not agree with me on this particular topic. And, I think you basically have to, you have to have an informed discussion with your clinician. They're going to bring their own preconceived biases. And, the things you should take into consideration are the cost and the likelihood of response and issues around resistance and antibiotic stewardship.
Maybe we can touch on histamine intolerance real quick. Does that overlap with IBS?
It can. This is another really controversial topic. I think one bit of evidence that really caught my eye from a number of years ago, I used to be the co-editor-in-chief of the American Journal of Gastroenterology, and our first special issue was actually on the role of food in gastrointestinal disorders. And as part of that request for manuscripts, we got a paper from Magnus Simron's group in Gothenburg, Sweden. And Magnus reported this data from a survey that he conducted in over 280 patients with IBS, in which they found that 84% identified food as an important trigger for their symptoms. And, that was important, but already known. But what was interesting is that of the different types of foods, like carbohydrates, proteins, fats, foods containing histamine, the two food groups that were most likely to reproduce a patient's IBS symptoms were carbohydrates. No surprise, right? Because we all now accept the importance of FODMAPs. And the second one was histamine-containing foods. Now, the way they administered this survey, they didn't say that the foods that the patients were checking off contained histamine. they listed foods, and they retrospectively figured out that these were histamine-containing foods. So that really caught my eye, because before that, people had sort of whispered about this, but never really talked about it. And there's been surprisingly little literature to really follow up on that, probably because it's not that easy to study this. But people have played around with low histamine diets, so excluding things like blue cheese, for example, that has a lot of histamine, or other specific foods that contain a lot of histamine. But really nothing in a carefully done, scientifically credible manner. So it remains in the shadows as a possibility. There are little bits of evidence from studies, a variety of studies like metabolomic studies and biomarker studies, which have also implicated histamine as an important factor that's abnormally metabolized in patients with IBS. So there are little hints that it may be important, but in my mind, it is not. There's no evidence that I have really found credible to say that we should be utilizing, for example, a low histamine diet. FODMAP is an acronym that stands for fermentable oligodimonosaccharides and polyols, which are short chain sugars that your small intestine either has difficulty breaking down or just can't break down. So, for example, some people can break down lactose, right? Lactose is a disaccharide that's broken down in the small intestine by lactase, the enzyme, brush border enzyme lactase, to glucose and galactose. Remember that lactose as a disaccharide cannot be absorbed by the small intestine. It must be broken down to glucose and galactose to be absorbed. So only monosaccharides can be absorbed by the human small intestine. So in the absence of lactase, either because there's insufficient quantity or because the enzyme isn't working properly, lactose gets to the colon, where it serves as a food source for the bacteria that live in the colon, and it's fermented to produce hydrogen and methane gas that is released into the lumen, and short-chain fatty acids, which create an osmotic load. And that combination of luminal distension and a intense osmotic load can serve as a trigger for symptoms in patients with IBS. Because remember, IBS patients oftentimes have abnormalities in motility, so an exaggerated gastrocolonic response, and also visceral hypersensitivity. So they're more sensitive to luminal distension. So it makes perfect sense that FODMAPs may serve as a trigger for symptoms in patients with these underlying physiological abnormalities. A low FODMAP diet, the elimination phase of the low FODMAP diet, is associated with symptom improvement in around 50 to 70% of IBS patients. So it's in that same ballpark that I keep quoting over and over and over again. By the way, it's not like FODMAP is any magic bullet either, right? I mean, it makes the majority of patients better, but not that much more than the majority. So remember that the first phase of the low FODMAP diet program is elimination, or what I actually prefer to call restriction, because you're not completely eliminating FODMAPs, you're reducing the intake of FODMAPs, so you're restricting FODMAPs. If there's a benefit in terms of symptom improvement, and that usually occurs in between 2 and 6 weeks. So as early as 2 weeks, and certainly if you're at 6 weeks and you haven't gotten any improvement, forget it, just move on to something else. If you get benefit, then you start to reintroduce foods containing individual FODMAPs to determine a patient's sensitivity. So this second phase is called the reintroduction phase. And then in the third phase, you use the information that you learned from the reintroduction phase to personalize an individual's diet for more long-term use. So the idea is that you never leave a person on the full restriction any longer than you need to. And in fact, a study by Reg and colleagues conducted at multiple sites in the UK over an extended period of time, and I was as part of that authorship team. We looked at data over more than 4 years, and it turns out that the majority, probably 80+% of patients with IBS that go on low FODMAP diet are able to reintroduce and personalize over time. So it really should be the exception rather than the rule of a patient remaining on elimination.
Briefly, the elimination, the foods that are eliminated in the low FODMAP, just for someone who may never have heard about this, would that be things like allium family, cruciferous vegetables, beans and lentils, some fruits? Are those?
Yes, all those things. I think the most, this is some other interesting research that we've done, and Jan Tak has also done some really interesting research in this regard. More than a year ago now, both Jan and my groups reported data from a structured reintroduction study. So what we took FODMAP responders, and then we blindly or in a blinded fashion reintroduced the 5 FODMAP categories individually, one at a time, to determine which categories were the ones that were most likely to reproduce a patient's IBS symptoms. And the good news is both of our groups actually found that by far and away the most important category are the fructans. And to your point, what's in that category? Well, garlic and onions.
And wheat,
garlic, onions, and wheat,
right,
are going to be the most important triggers in terms of things that. And by the way, both our studies showed that different patients react to different things, but the one that was most consistently a problem were fructans, but that wasn't universal.
One very common question is people experience an improvement by removing these foods, and then when they're told to reintroduce them, it's very counterintuitive, and a lot of people ask, why would I introduce something that caused problems before and I feel fine now? Why would I even play with that? Why not just stay in my restricted diet forever?
Yeah, because variety is the spice of life. And, I say that about everything, including diet. I think that all of us would acknowledge that a diverse, balanced diet is going to be healthier for a person, particularly over the long haul, than a highly restricted diet. The other, from a pragmatic standpoint, if we implicate the microbiome again, we also know that the more restricted your diet is, the more restricted your microbiome is. And diversity in terms of your microbiome is a very important factor in terms of determining not just gut health, but your overall health, your metabolic health. So it's important for people to think beyond only the impact of your symptoms or on your symptoms in regards to when you're on that restriction phase. The restriction phase should be viewed as a diagnostic test to determine whether you're sensitive to FODMAPs or not. Nothing more, nothing less. And it should not be viewed as a means to an end, but as a diagnostic test to determine whether or not you should go on to the reintroduction and personalization phases. And the end game is to figure out what your low FODMAP diet is, not just the FODMAP restriction for everybody, but what foods you need to restrict to be able to get back control of your life and to be able to not suffer incessantly with your symptoms.
In terms of these foods that the person determines that they have an intolerance to, are those foods then outlawed for life, or is there a possibility of rehabilitation of the gut, maybe by gradual ramping up with cultivating the microbiome?
Great question.
Yeah, is that a possibility, or is that
and we don't know the answer to that, right? But I think that it's like patients ask me all the time about this. They say, well, does this mean, is this a forever thing, or can I, try to, and I strongly encourage them to experiment. Here's the reason why. One is because I think there can be some adaptation over time, particularly when you're using multiple strategies. Secondly, so for example, when you're using a behavioral strategy or a neuromodulator or any of a number of other like laxative therapies or prescription therapies for IBS-C symptoms, for example, you may get incremental benefit from all these things together, like we talked about, as opposed to just thinking about them all individually. So retrying foods at set intervals just to make sure that you understand how much you can get away with before it causes problems, or if maybe it doesn't cause problems anymore, I think is a really valuable exercise. And here's the other thing about that that's so important, because people will say, God, it was such a failure. I developed symptoms. And I say, I'll turn around to them and say, no, it wasn't a failure. You know why? Because we know you need to still restrict the food, right?
Mm-hmm.
We know that now. We didn't know that before. So I don't consider that a failure at all.
Mm-hmm.
I consider that as
yeah.
permission to continue what we need to do to help you to feel better.
Mm-hmm. On the topic of this heterogeneity and this individual variability, we get a lot of anecdotal reports, as you might imagine, from different viewers, and we get diametrically opposite stories of people who had IBS. And some found relief by removing a lot of plant foods. Others found relief by eating only plant foods and removing all the animal foods. And both swear that it completely turned their health upside down in a good way. So this is very striking for a non-specialist like me, a non-gastroenterologist, to see these very, very opposite stories, seemingly opposite stories. So do you think this is just at baseline, they had different sensitivities, or is it maybe a common thread that maybe they eliminated processed foods in both cases? Do you have some thoughts on that?
Oh, yeah, I do. Yeah, absolutely. Because I've thought about this a lot. And in fact, our research program is built around this very observation, which is that, if you ask me, I would tell you that probably 50 to 60% of patients on low FODMAP get better. Now that's great, but that means that 40 to 50% of the patients don't get better. And by the way, I only put patients that say that their symptoms are triggered or worsened by eating a meal on a diet strategy. Right? So these are patients that have food-related symptoms, but yet they still don't get better on the low FODMAP diet. I believe that the low FODMAP diet is important not only because it makes around half of the patients better, but because it opened our eyes to the fact that diet interventions can be really valuable parts of the treatment plan for patients with IBS. But I don't view the low FODMAP diet as the diet for IBS. Not at all. I view it as a diet for IBS. And so it's our obligation as researchers and innovators to think about how else we can tailor the diet in IBS, either through the use of biomarkers or through the use of other empiric strategies to benefit that other 40 to 50% that don't get better on the low FODMAP diet. So right now, for example, we're really excited about the Mediterranean diet, and we're utilizing the Mediterranean diet as an alternative diet in patients with IBS who don't want to go on the low FODMAP diet or who've tried the low FODMAP diet and have not responded. We're doing a study right now comparing the low FODMAP diet to the Mediterranean diet, and we'll, hopefully have results from that, a pilot study on that within the next year. So we should not view the low FODMAP diet as the end of the story. We should view the low FODMAP diet as opening the door to getting on the pathway to identifying a whole bunch of other ways in which we can manipulate the diet to benefit the patients with IBS.
Mm-hmm. You've seen some patients where a low FODMAP diet did not help, but a Mediterranean did?
Absolutely.
Interesting. And probably some where it was the other way around, right?
Yes, absolutely. Yeah. Fiber is a complicated discussion because people think about and talk about fiber, at least doctors do, like it's all the same thing.
Right.
One fiber supplements. I recommend patients take methylcellulose or calcium polycarboxyl or psyllium or inulin, it's all the same thing. Well, guess what? It's not all the same thing at all. They're actually quite different. And, if you think about issues around fermentability, solubility, there are dramatic differences that affect the performance of fiber from one person to the next. So just some general things. I'm not going to say the same things that everybody else will tell you. I'm going to tell you some different things. So the first thing is just to realize is that fermentable fibers like inulin do not add bulk to the stool. Remember that inulin is a FODMAP, right? It's the fructan. So it's universally non-digested, not absorbed by the human small intestine, and it's universally deposited in the colon, where you may or may not have bacteria that will break it down, will ferment it to gas and short-chain fatty acids again, right? And that's how it exerts its laxative effect. So it's actually a prebiotic fiber. So it's a non-absorbed, non-digested, or in the small intestine, carbohydrate that is fermentable in the colon, and it offers prebiotic effects. So it tends to favor the growth of certain organisms, and it also leads to fermentation byproducts, which can have a laxative effect. So that's just something for people to realize. I don't think even doctors realize that. The second thing is with regard to bran, which is an interesting discussion, because we talk about fermentable fibers like psyllium and isbagula husk as being the ones that are most beneficial for constipation, for example, and IBS. And that's true. Based on the literature we have right now, the best evidence that we have is for psyllium and isbagula husk. And of course, isbagula husk is psyllium. They're basically the same thing. The bran has been largely poo-pooed. The evidence for bran and IBS is not compelling. But one thing that's important to understand about bran is whether or not that bran has a laxative effect is highly dependent upon whether it's coarse or fine bran. This is another thing that I think most people don't even think about, but realize that coarse bran actually has an irritant effect in the colon and will stimulate people to go to the bathroom more often. Fine bran actually can be constipating. So those are some comments, a little bit different perspective on fiber that I bet probably nobody has heard about before, but those are important factors to take into consideration. You've got to understand what kind of fiber to use in a specific clinical circumstance. Like for constipation, you would not want to take coarse, or you would not want to take finely ground bran. It's not going to help you. May even make it worse. The ACG and AGA guidelines on IBS did not favor widespread use of probiotics for IBS based on the current evidence. Now, that was largely related to the fact that for individual probiotics, there wasn't, with a few exceptions, there isn't compelling evidence of benefit for overall IBS symptoms. Now, the good news about probiotics are that they're relatively safe. They're widely accessible. And there is some evidence for individual probiotics, like, for example, Bifidobacter infantis 35624, which is a line. There are 2 randomized controlled trials suggesting benefit for overall IBS symptoms with that probiotic supplement. There's some data for the old VSL number 3, not available anymore, but for flatulence and bloating. There's also some evidence for Bifidobacter animalis, which is the Activia yogurt to increase stool frequency. But unfortunately, most of the literature is not scientifically or methodologically rigorous And for that reason, it's hard to have a lot of confidence in the results.
Mm-hmm.
For that reason, the AGA said outside of a clinical trial, they don't recommend the routine use of probiotics for IBS. And the ACG made a fairly similar recommendation that at the current time, it's not recommended. Probiotics are not recommended as routine treatments for patients with IBS. I mentioned to you a couple of probiotic supplements for which there is evidence. There's also evidence of some probiotic strains to actually improve emotional function. So things like anxiety and depression in patients with IBS, published by the McMaster Group, by a number of investigators up there. And there's actually ongoing studies looking at a specific bifidobacter strain as a potential treatment for some of those emotional symptoms in patients with IBS. And the comments I'm making make it sound like that I'm not very enthusiastic about probiotics as a treatment for IBS, and I'm not, to be frank. I've actually come full circle on this. I was very excited when they first were on, starting to be discussed. But as time has gone on, I've become more cautious. Now, that said, I personally think that probiotics will eventually be part of our strategy for IBS. But the problem is right now, using this empiric approach, picking one strain, maybe several strains, and just sort of dumping them into IBS patients who we've already talked about are a very heterogeneous population of individuals. You really have to ask yourself, does that even make sense? Does it even make sense that you'd expect that taking one strain of a probiotic, or even like 4 or 5 strains of a probiotic, and putting them into an individual with a unique microbiome, whether that makes sense that it's going to be a benefit? And I would argue to you that it probably doesn't make a whole lot of sense. And so at some point down the road, when we're able to profile the microbiome and better understand what a patient needs, and by the way, people may in your audience may say, "Oh, well, those tests are already available. I can go into this place and they'll collect my stool and run my microbiome, and and then can tell me what I need to supplement." I wish it was that simple, but it's not. We have a long ways to go before we can feel confident about the robustness of the results of the testing and the veracity of the recommendations that we make for an individual from that testing. I think both those things are in question right now. Mm-hmm. I think I'm optimistic about the promise of probiotic therapy, but I don't think we're there yet.
Mm-hmm. And for probiotic foods, your view is the same?
Yeah. I think the good news again about, particularly fermented foods is there's little downside to doing that. I mean, people have been eating fermented foods for millennia, and they're clearly safe. They may offer some health benefits. So it's worth a try, and I'd say the same thing about probiotics. It's worth a try. But if you do that, give yourself a time limit, 2 to 4 weeks. And if you don't get better after 2 to 4 weeks, move on to something else. Don't keep doing a strategy that costs money and doesn't work.
Okay, quick summary of everything we covered. IBS is a heterogeneous condition. As Dr. Chey explained, it's not one disease. Some people have predominantly constipation, some have predominantly diarrhea, and some have both. Other symptoms are also common, like bloating, gas, and psychological symptoms, like anxiety and depression, for example. But the definition of IBS is abdominal pain coupled with altered bowel habits. Causes of IBS can vary from person to person, but the most common triggers of symptoms are food and stress. Conditions that often mimic IBS and that can co-occur with IBS include inflammatory bowel disease, celiac disease, non-celiac wheat intolerances, and SIBO. small intestinal bacterial overgrowth, among others. And for several of those, there are specific tests that Dr. Chey went over. There are several therapeutic strategies. There are mainly three pillars. One is diet, like the low FODMAP diet. Another is behavioral therapy, like hypnosis, cognitive behavioral therapy, and others. And finally, pharmaceutical agents, like antibiotics, laxatives, or antidepressants. And then there are things like probiotics and acupuncture, which may have some benefit. In some cases, there's some evidence for them, but presently the evidence isn't as strong. Now, each strategy in isolation can help some people, around 50%, give or take, usually 40-ish to 60-ish. But the real power is in combining approaches. That's where we see a success rate of 80% and upwards. As for elimination diets, like the low FODMAP diet, it's important to understand that the dietary restriction is the beginning, not the end. There's also a reintroduction phase and a personalization phase. And over 80% of patients are able to reintroduce a lot of foods and tolerate them just fine. I shared in an old video an anecdotal situation in my family where we were able to reintroduce a lot of the foods with a lot of success and overcome intolerances. Obviously, it's just an anecdote, so it's got very limited weight, but Dr. Chey cited some studies that align with that experience. If there's interest, we can make more content on this and maybe get a registered dietitian with experience in this specific area and go over this restriction phase and the reintroduction phase and all of these steps in detail. So low FODMAP diets are evidence-based. They help between 50 and 70-ish% of people. But just like all the other approaches, they don't work for everybody. And there are ongoing studies looking at other dietary approaches. So ideally, we want to work with a team, gastroenterologists, registered dietitians, and behavioral therapists. Of course, not everybody's going to have that luxury. I get that. But it's good to know that these resources exist out there. So if one thing didn't work for you, it doesn't necessarily mean there's no hope. We actually had this exact experience with my family as well. We didn't get the answers from the first or the second or the third specialist. We had to keep knocking on doors, and eventually we solved the issue. In my mom's case, the critical step was the dietary tweaks, the elimination and the reintroductions. She never really got into the medications or behavioral therapy. The diet fixed things. But again, not everybody's the same. So the key is to find the combination that works for your condition. I hope this all helps. Let me know your questions below. I'll catch you guys next week. Bye-bye.